and Dr. Beena Singh Madam from Bijnor. So all have kindly consented to be chairperson to chair that very session. And as far as panel is concerned, legal issues in labor and particularly in sudden obstetric collapse, we are going to discuss that very topic, and it is reverse panel. Panelists will be asking question, and being a moderator, I will be answering. So for that, I invite all the learned panelists, Dr. Garima Trivedi Madam from Prayagraj, Dr. Uma Jaiswal Madam from Prayagraj, Mrudula Sharma Madam from Bareilly, Dr. Gayatri Singh Madam from Bareilly, Dr. Latika Agarwal from Bareilly, Dr. Pramila Mittal Madam from Bulandshahr, Dr. Indu Singh Madam from Bulandshahr, Dr. Poonam Agarwal Madam from Firozabad, Dr. Garima Sharma Madam from Firozabad, Dr. Sanjaya Sharma from Jhansi, Dr. Alka Sethi Madam from Jhansi, Dr. Vidya Chaudhary from Jhansi, and Dr. Rekha Singh from Sultanpur, and Dr. Swati Madam from Sultanpur. I also welcome Dr. Asha Jain. She is convener in this series since long. So welcome, Asha. I also welcome to coordinator Dr. Rekha Rajendra Kumar, President of Bengaluru OBGYN Society. She is also coordinator in this series since long. And with special mention, I would like to welcome Dr. Ritu Khanna also. She is also one of the coordinator for this webinar, and she is instrumental as far as this program is concerned, this webinar is concerned, not only from designing, but up to execution of this program. And Ritu Khanna is very hardworking person. She is chairperson of Food, Drugs and Medical Surgical Equipment Committee, FOXY. And she has helped me a lot as far as any academic activity is concerned. And she is always ready. Whenever I call Ritu, she will always say, yes, ready, what I have to do. So thank you, Ritu, and welcome to this series. And I welcome all the president and secretary of Joining Society and all the delegates who have joined this webinar. In era of COVID-19, when I started this series with 3 friends, I never know that this series will be continued like this. And now I am happy to announce it is more than 7,000 plus member as far as this Happy Learning Masterclass web series is concerned. We discuss focused topic, and this year, this is our 4th round with all Foxy Society. And in this series, we have started reverse panel, and it is well appreciated all over India as far as this panel is concerned. So without wasting much of your time, thanking you all and welcoming you all again. Thank you very much.
Thank you, sir. Thank you. May I have the CV of Ritu ma'am?
Asha,
Yes, ma'am.
Yeah, I think sir's
Ma'am,
already.
I'll say a couple of lines. We'll display it and then I'll say a couple of lines because you are our respected coordinator and I would like you to say a few words before we go on to our chief guest and guest of honor. Where's the CV, bhai? So Ritu ma'am
This is the only thing.
the chairperson, Food, Drug and Medical Surgical Equipment Committee, FOXY, as sir already said. She is a member, she's an executive member of SFM. She won with the highest number of votes. She is also the vice president of IFS. So over to you, Ritu ma'am, for a few words.
Thank you, Dr. Asha. And heartiest congratulations to Dr. MC Patel, sir, for this, continuation and coming to the 188th edition of the Happy Learning Masterclasses, sir. And I think this is the most demanding and an amazing learning session. Thanks to our convener, Dr. Asha Jain, and my co-coordinator, Dr. Rekha, who have been very, very active, and they've always put in so much of hard efforts to bring us all together. So best wishes, Dr. Asha, who is the candidate for the Food and Drug Committee. Best wishes to you and also to Dr. Rekha for taking over as president and for our future endeavors. And my heartfelt gratitude to our chief guest, who are our mentors, Padma Shri, Dr. Raj Babeja, madam, and Dr. Narendra Malhotra, sir. Ever inspiring, I must say. And they've always shown us the path to keep moving, and they always stand by you. Thank you so much, sir, for joining and always blessing us. My gratitude to Dr. J.K. Goyal, sir, and Dr. Lata Agarwal, madam. I yet to have seen any time when they ever said a no to us. They may be so busy, but they'll always have the time for us, and that's the love and support. Thank you, ma'am and sir. And our loving, ever loving Manju, madam, the fantastic art of teaching that she has, and having you accepted our invitation. Thank you so much, madam. Our special thanks to our friends from Bareilly, Dr. Nida, Dr. Mridula, Dr. Gayatri, Dr. Latika, all very loving, and we love to work together always. And from Prayagraj, we have Dr. Shubha Pandey, Dr. Uma, Dr. Garima, Dr. Alkas joined from Jhansi, Dr. Sanjaya Madam, Dr. Vidya, and Bijnor, Bulandshahr, Dr. Pratima Ma'am, Dr. Inam Singh Ma'am, so very loving. And from Firozabad also, we have Dr. Poonam, Dr. Garima. Sultanpur, we have Dr. Rekha and Swati, all very dear to us. And thank you for joining, for giving us your inputs today and making it a great learning session. So all our blessings and best wishes to the Happy Learning series. Thank you so much.
Thank you, Dr. Ritu. Now, I would like to introduce my coordinator, Dr. Rekha Rajendra Kumar ma'am, who's the current president of Bangalore Society. She's been with us in this series for a long time. She has 32 years of experience and she has held a lot of positions in Kasoga, has many awards and felicitations.
You
Yes.
can move forward.
Thank you, Dr. Rekha. Thank you so much for being with us consistently over such a long time. Now, I would like to have the honor of introducing our chief guest, Dr. Narendra Malhotra, sir. May I have his CV, please?
Yes, ma'am.
Welcome, sir, to this 188th episode of Happy Learning Masterclass. So that's a really very busy CV. Sir is a professor, managing director of Global Rainbow Healthcare, director ART Rainbow IVF, director Foxy Smriti Manyata CSE, VP Society of Ovarian Rejuvenation, director Project Positive Health Rotary District, director International Relations SAFOG, national director Ian Donald School of Ultrasound, Professor Sarajevo School of Science and Technology, Croatia, Professor Dubrovnik International University, Croatia, Professor IMA, past VP SAFOG and WAPM, past President Rotary Club of Agra, Taj City, past President ISAR, ISPAT, IFUMB, Foxy, AOGS, ICMU, INSARG, founder editor SAFOG. We all know him. I could just go on reading it. So welcome, sir. We are really delighted to have you with us this evening.
My pleasure, my pleasure. Very good evening to all of you. Congratulations, dear friend, Dr. MC Patel, for doing this 188th Happy Learning program. See, what a lovely name, Happy Learning. We all need to be very happy and we need to be very happy learning things and trying to improve ourselves. When we improve ourselves, we're going to be much more happier and happier and happier. So that is exactly what life is all about. Be happy, keep on learning. Life is a teacher. Everyone is a teacher. The junior is a teacher. Everyone in this world teaches someone something. And if you learn it happily, you will be very happy. What I see today is such a galaxy of panelists, speakers, chairpersons, moderators, and of course, the Mr. White Man, Dr. MC Patel, who we all admire for his presence everywhere and for his great knowledge about medical legal aspects and his lovely free advice to anyone in Foxy who gives him a ring to ask if they're stuck in a medical legal problem. That's what our dear MC Bhai is. And thank you for inviting me here for as chief guest here. The program is Dr. Manju Verma, again a very close friend of ours, going to talk on rupture of unscarred uterus. Now, a lot of people will say, what is there? Uterus don't rupture unscarred. They do rupture. It is a problem. And it is a problem when you're not expecting a rupture of an unscarred uterus. So please listen to that very carefully and be ready to try to pick those things up which can lead to uterine rupture in unscarred uterus and scarred uterus in pregnancy. And of course, labor is a challenge. Labor in delivery is a challenge. Sudden obstetric collapse is a reality, and we all are unable to explain why this patient suddenly collapsed. She's delivered nicely. 5 minutes later, she just collapses, breathless, and you are unable to resuscitate her so many times. And then what do you tell the you came and said, "Congratulations, you have had a boy. Everything is normal. We're just shifting the patient to the ward, and on the stretcher, she has collapsed and unrevivable." So what happened? And that is when the attendants and the relatives will get very, very aggressive, upset about it. So how to medico-legally deal with this great, terrible problem, which is a shock to the obstetrician and to the family, is what Dr. MC Patel will do in this unique reverse panel. MC Bhai, I'm also going to do these reverse panels now, from now onwards. I have to do one only on IUI. Now I'll just put them that it's going to be a reverse panel. So
Yes.
that would be a great idea of trying to solve out the problem and listen to the questions which these youngsters will try to stump you with. So congratulations once again. Thank you once again for inviting me. All the best for all your future endeavors. All the best to this happy learning program. And I'm sure you're going to cross 200 in 2 months, next 2 months, and maybe 250, and maybe later on 500. All the best to all of you.
Thank you. Thank you, Dr. Naren sir, for sparing time to bless the webinar. Of course, you are always with us in any of our activity, and just I mentioned in prior also, your mere presence is enough to inspire all of us for any of the activity. Thank you very much. And as you said about sudden obstetric collapse, yes, it is, of course, it becomes, it is rare, but whenever it happens, then it becomes nightmare for any obstetrician, and it becomes very difficult how to deal with the situation, and then after how to deal with medical legal consequences if at all it happens. So in this type of situation, as far as this reverse panel part is concerned, we discussed those points in a panel. And as far as this reverse panel part is concerned, it is well appreciated, because now not only in webinar, but in conferences also it has started, and we do a reverse panel. Just a day before yesterday also, I did the same panel at Vadodara in physical meeting, and they were so happy, because whichever question related to our obstetric or gynec practice as far as medical legal consequences are concerned, and they come up with all the question and situation or scenario rather, that in that very particular patient this happened, and now you discuss where thing went wrong and why this litigation happened and why this result came against doctor. So in this type of situation, it becomes very interesting, and let us see, today also it will be the same. So thank you, Naren sir, for sparing time again to bless the webinar.
Thank you, sir. Thank you, Naren sir. Now I would like Dr. Rekha Rajendra Kumar ma'am to introduce Dr. J.K. Goyal sir.
Thank you. Thank you, Dr. Asha. Thank you, MC Patel sir, for the opportunity. It's my pleasure to introduce one of the guests of honor of today's program, that is none other than Dr. J.K. Goyal sir. Sir is MBBS, MD and FICOG. He is Professor, Medical Superintendent of Saraswati Institute of Medical Sciences, Hapur. He is ex-professor and HOD in Bareilly, again from Hapur. Sir has lot of awards and experience of more than 4 decades. He's been a principal and chief medical superintendent, vice principal, etc. And lot of different cadres sir has worked and authored many chapters also. and he has a solid experience of more than 40 years academically. His area of interest is high-risk obstetrics, emergency obstetrics, and infertility. So, sir is the apt person as guest of honor for today's program. We heartily welcome you, Dr. Goyal, sir. We would like to hear from you. Over to you, sir.
Thank you, ma'am. And good evening, everybody. At that outset, I congratulate and convey my gratitude to our program director who is conducting that happy learning and master classes edition 188, the convener, Dr. Asha Jain, coordinator, Dr. Rajinder, Dr. Mrs. Rekha Rajinder Kumar, Dr. Ritu Khanna. I am definite in saying that this is a very session will be highly useful and for everybody, and everybody will be benefited immensely. Topic chosen for this subject for this session is highly useful to everybody in today's practice, in particularly when the legal issues in labor and sudden postpartum collapse. Every obstetrician has to face this frightening situation in one or the other time during their lifetime. Obstetrics is a very challenging, demanding, and highly volatile discipline of medicine. Pregnancy is a physiological state of in a human life, but poses unique challenge, and losing a young woman in a productive age group where results desired are perfect one is not accepted by any of the relations or by the society. Significant litigation with negative judgments are there in our discipline as comparison to the other subjects. This is attributed to wrong diagnosis, wrong decision making, poor supervision, intraoperative complications, and retention of foreign body during surgery. Ignorance of law is not excuse for its breach. Legal system does not condone lack of awareness. So it is necessary that everyone has to be conversant with the legal issues. As far as uterine rupture in scarred uterus is concerned, at times it becomes very difficult because patient comes very sick, very ill, and presentation is normally very acute and patient is very much shocked. Different causes of that uterine rupture, as it will be told by the speaker, Dr. Manju, there is a most common cause is that manual removal of adherent placenta, or in cases when that one has undergone curettage for incomplete abortion.
मीटिंग है वो आशा जैन का फोन आया था ना डॉक्टर आशा
In
जैन
subsequent pregnancy in these cases. Then the cause is that once the patient present with accidental hemorrhage, in those cases also occasionally one may present with uterine rupture. There are a number of cases where no cause is found, and in those cases most likely cause, and that is to be seen in grand multiparity. Rapid and recurrent births, they causes, and they uterus is not able to withstand the stress of labor. As far as normal labor is concerned, that legal issues in obstetrics, it is very unpredictable, and most of the normal labor go in a minute into abnormal labor. A successful delivery can turn into a disaster. Obstetrician judgment has to be sure and swift. Errors of commission carry penalties greater than omission. Increased experience of that obstetrician sharpens the alertness, and there is no room for complacency in obstetrics. Sudden postpartum collapse is a frightening situation, and in most of the cases, the cause is that hemorrhage. But in some cases, there may not be that revealed hemorrhage. That is about 500 cc. Patient suddenly goes into shock. One has always to suspect about that intraperitoneal hemorrhage, internal hemorrhage, or it can be retroperitoneal, it can be that extraperitoneal. common causes of postpartum hemorrhage without bleeding are eclampsia, uterine rupture, pulmonary embolism, that may be due to air embolism, or that may be due to that amniotic fluid embolism. One has to have an effective to reduce that maternal mortality and morbidity. One has to have that effective management that requires frequent training of that labor room staff. Plus, one has to have that mock drills. Standard protocol has to be followed up. Then only we can save this catastrophe. Thank you very much. And again, I wish all the best for this happy learning master classes. Thank you very much.
Thank you, G.K. Goyal sir, for sparing time and your expert comments as far as the today's subject is concerned. Thank you, sir.
Thank you, sir. Sir, may I read Raj Baveja Madam's CV? Or should we proceed next? Patel, sir?
No, she has bad sore throat, she told me. So if at all she
Okay.
can join, then we will have blessing at that time and we can proceed accordingly. No issue.
Okay. So may I have the next CV, please? So I would like to welcome Dr. Lata Agrawal ma'am, who's a professor at Rohilkhand Medical College Hospital, Bareilly. Next slide, please. She has organized many conferences and workshops, and she's organized a urogynec workshop along with Bareilly Obstetric Gynec Society. She's participated as chairperson in national conference, and she has successfully organized advanced lab workshops along with DOGS, successfully organized colposcopy workshop and also hysteroscopy workshop. So over to you, ma'am, for your blessings and words of wisdom. Lata Agrawal, ma'am, over to you.
Madam, please unmute yourself. Dr.
You are
Lata
muted,
Agrawal,
madam.
madam.
Lata, ma'am, you are muted.
She is unmuted.
Ah,
Yeah, please.
I've unmuted myself.
Correct.
A very good evening to one and all. And I am especially grateful to Dr. MC Patel and dear Dr. Ritu Khanna for considering us to be guest of honor in such a lovely webinar. Sudden obstetrical collapse, nightmare for every obstetrician. And I'm sure all of us sitting here have experienced this in our lifetime, during our practice. So whenever there is sudden obstetric collapse, I would like to tell my juniors, sit down in the labor room, think, don't get upset. Think what you are going to talk to your attendants. Because a few minutes ago, we have, like Dr. Nareen said, we have congratulated them. We come back into the labor room, the staff tells us, Madam, she's no more. So we should sit down, first collect our wits all about us, and then go and meet the attendants. Because if the attendants feel that we are not sure about what we are saying, they are going to create a ruckus. So I'm sure Dr. MC Patel will guide us better in how to manage this situation. And if we can save the woman with sudden obstetric collapse. All rupture of the unscarred uterus, patients do not give us history that they have undergone so many DNCs. There may have been a perf which we are unaware about. So we must be very cautious when patients come to us and take the history very carefully, trying at every time to find out कि DNC तो नहीं हुई थी, DNC तो नहीं हुई थी. Otherwise, she's not going to tell us. I think a lot has been said when we should start with the webinar. So thank you all and greetings from my side.
Thank you, Madam Lata Madam, for sparing time to bless us. Thank you.
Thank you, sir. With this, we come to the end of the inaugural session. I request Dr. Rekha ma'am to introduce the chairpersons of the first talk.
Thank you, Dr. Asha. We have two sessions in the academic part. I'm talking about the session 1, where we have 3 chairpersons who will chair for a talk on rupture of unscarred uterus in pregnancy, and the speaker is Dr. Manju Verma. I would like to have the CV of Dr. Neera Agarwal, Madam. Yeah, thank you, Teeth. Dr. Neera Agarwal, Madam, graduated from King George Medical College, Lucknow, post-graduation also from the same institute. She has organized infertility and ultrasound workshop at Bareilly. She has also presented a paper on fibroid in pregnancy. She has chaired a lot of sessions in many of the academic wings of FOXI, ISAR and IFS. She is a life member of Indian Fertility Society. Thank you and welcome, Dr. Neera Agarwal. We are happy that you chair this session. Can I have CV of Dr. Shubha, Madam? Shubha Pandey. Yeah, thank you again. Dr. Shubha Pandey, Madam, is HOD of Obstetrics Gynecology in Kamala Nehru Memorial College, Prayagraj, also president of the same society, renowned professor for more than 4 decades, and she has done a lot of contribution in the field of infertility as well as a postgraduate teacher. Thank you again and welcome, Dr. Shubha, Madam. We are happy that you are here to chair a session on sudden obstetric collapse, the topic on the unscarred rupture of unscarred uterus in pregnancy. Thank you, Shubha, Madam. And again, can I have CV of third chairperson, Dr. Beena, Madam? Dr. Beena Singh is an alumni of 1983 batch of Meerut Medical College, and she is the owner of the Healers Hospital and Beena Prakash Hospital. Apart from the medical skills, she is the director of the Naturopathy Ashram that is situated in Hari district, Bijanur. Dr. Beena, Madam, again I welcome you. So welcome all the 3 chairpersons. Dr. Neera, Madam, will welcome the speaker, that is Dr. Manju. Dr. Shubha will give brief introduction about the talk, and I request Beena, Madam, to conclude the session with a concluding remark. Thank you, and I hand over the floor to the chairpersons to take the proceedings forward. Thank you again.
Thank you once again, and thanks Dr. MC Patel and Ritu for inviting me and giving me the opportunity to chair this session. It's a really very nice happy learning series, and I really appreciate the effort of Dr. MC Patel and Ritu to organize such a important talk, because I know nowadays obstetricians, especially young obstetricians, they are doing practice, I agree, but they are not very, they are all dependent on the sonological report and clinical experience, what we learned in our graduation and undergraduate, post-graduation level long back in 90s, 80s. Now that clinical experience somehow is lacking. So we need more clinical experience and to see the patient, and we have to see the consequences, what the problem, why this problem occurs. So today is a very important topic. I know Dr. Manju Verma very well, and she has visited thrice to Bareilly also, and I know she was visiting to KGMC as a examiner also. So I welcome Dr. Manjuji, and can you show the slide, please? CV of Dr. Manju Verma. Hello. May I have CV of Dr. Manju Verma? Yes. She is past president of UP chapter of OB-GYN, and she is she was HOD of the Kamala Nehru Hospital. We know she has presented so many papers, and she has been examiner for so many and colleges. She received the Prabha.
I think there's no need of reading all everything.
Yes, Manjuji, I know personally you, and you are coming to Bareilly again for
Yes.
this. Yes, UPCOG. Really, we are waiting for all of you to visit Bareilly. Yes, welcome Manjuji.
Thank
And
you.
yes, over to you, Manjuji.
Thank you, Neela, for the kind words. And I think I should say my heartfelt thanks to Dr. MC Patel and Dr. Asha Jain, the two sovereign personalities. Reminding you, such a senior people, reminding me that I have got a session today. And I'm really, really thankful to you and Dr. The conveners. Special thanks.
एक्सक्यूज मी मंजू मैम, आपके पास कोई मोबाइल रखा हुआ है क्या? आपकी आवाज एकदम लहरा रही है. 2 डिवाइस होंगे तो आवाज बहुत लहरा रही है.
नहीं, ऑन तो कोई डिवाइस नहीं है.
नहीं, have you joined with only one device or 2 devices?
Device only.
मैम यदि मोबाइल आसपास रखा हो तो थोड़ा सा दूर कर दीजिए, आवाज बहुत लहरा रही है.
Yes, that is possible because mobile was with me only. Is it clear now?
A little better, but not very much better.
Mobile off. I'm sorry for the inconvenience, but I would like to again thank MC Patel and Dr. Asha Jain, such senior people, and reminding me that I have got a session today. I'm really, really thankful to you, and I am my special thanks and love with you. Wish you the first but to come to phone me up that for the webinar. I'm really thankful to you, Ritu, and Dr. Rajkumar, and Dr. Babeja. Yes, Dr. Babeja and Dr. Narendra Rudra. I am really thankful to you people also for joining at this time. The guest of honor, Dr. Goyal, and the persons. Then Veena, Subha, and Veena. I think I would like to say that I might have been examiner of issue. And before wasting my time, I would like to go on to the topic straight away. Can you hear me? Hello? Hello, can everyone hear me? Hello?
Yes, ma'am, we can hear you, but it's not very clear. It's still not very clear. You need to
we
maintain
will try,
a
madam.
fixed distance.
Please switch off your video, and if it audio becomes little better.
No.
Ma'am, you may share screen.
Just a minute, I'm just going the video. I've been trying to put it off.
बेटा वो बोरा वहां से हटा के कहीं और रखो.
Hello. Can you hear me now? Can you hear me now?
Yes, madam. Make it full screen.
Oh, on to, and as already been said that uterine rupture of an unscarred uterus is a catastrophic obstetric emergency which is associated with the significant maternal and fetal morbidity and mortality. And as already been said by Dr. Goyal, that the maternal mortality ranges from 1 to 3% with perinatal mortality ranging from as high as 74 to 92%. Every second is vital. for the survival of the patient as well as for the fetus. Just as it is customary to define, the definition of the rupture of uterus, as we know, is a non-surgical disruption of tear of myometrium with or without cirrhosis, with or without expulsion of the fetus and the placenta into the peritoneal cavity. So many times that we may not be able to find out an identifiable etiological factor or a risk factor, and it occurs especially during labor, as we all know, and it is likely to occur in the last week of pregnancies. Now, coming on to the incidence, it's been noted to be as maybe as to a point 0.5 all pregnancies, and the worldwide median has been said to be as much as 3 per 10,000 delivery. Comparing the unscarred uteri rupture to the scarred uteri rupture is that the unscarred is 0.07% and the scarred is 5.1 per 10,000 deliveries. The incidence is much higher if the uterus is already scarred as compared to the uterus is scarred. Coming on the difference between the developed countries, high income group, the incidence is much lower as compared to 2000, and the overall incidence, which has been by the WHO reported to be 1 in 1.36% pregnancies, taking an incidence of 0.07% all over the world. Now, coming on to the IPMR has reported incidence of 0.28%, and they have also found that the undiscovered pregnancy 3% as compared, is 14% as compared to 33%. Now, coming on to the etiological, so the risk factors are basically uterus has got some problem like maybe like at the cornwall end, or maybe it is genetic or then loss syndrome. Maybe factors like trauma, which is usually a traffic accident, maybe a domestic violence or a blunt abdominal injury. Certain procedures like extraction may sometimes result in uterine rupture of an unscarred stitching of uterus. Rare though can result in rupture, like in cases of hydramnios, multiple pregnancy. Placental conditions has already been mentioned of placenta and placenta percata because of the weakness of the myometrium result in rupture of the uterus. Coming on to the history, the grand multiparas are much more have uterine rupture unscarred compared to the paras. A short pregnancy interval has been reported to have an incidence of 12% of the whole incidence. Still, hydrocephalus and macrosomia can sometimes result in uterine rupture. Prostaglandins being used in the second trimester for abortion has been noted to be one of the risk factors, and unfortunately, the uterus, like incarcerated retroverted uterus having an anterior circulation, can also result in the rupture of the uterus, which is unscarred. This is just predisposing factor is showing that multiple age, black races, multiple pregnancy, parity, and eclampsia, chorionic chorionitis. This with the confidence interval and the odds ratio more than once, they are more prone to have the uterine rupture, which is unscarred. Now, coming on, it can be complete or incomplete. Complete rupture can be just because disruption of the pregnant uterus. This may be with or without expulsion of the content of the be like just the placenta in the peritoneal cavity. Partial rupture is basically when the ring is still intact or rupture is into the lateral wall going into the sites for uterine are usually unscarred uterus. These sites are basically the cornwall, and the left cornwall is supposed to be more common as the right. And the lower segment rupture and the lateral wall rupture are the other places where the unscarred uterus can rupture. Coming on to the signs, typically, if it's signs there is sudden patient complains of sudden tearing abdominal pain, cessation of uterine contraction associated with vaginal hemorrhage or hematuria. There may be features of maternal tachycardia and hypertension. The intra-abdominal hemorrhage may patient complaining of chest pain or a shoulder tip pain with shortness as if there is a large amount of peritoneal hemorrhage. The fetal on examination, the fetal parts becomes easily palpable. Fetal heartbeat and the contraction are not felt with the uterus being shifted to one side and the fetal parts can be easily felt. Typically, in complete rupture, the patient presents with abdominal pain and tenderness. They rank signs of develop slowly as complete rupture. Fused with accidental hemorrhage so many times, one has to be very so the case says that what are the presenting symptoms in case rupture? Common is the abdominal pain. One can see the loss of movement. The rupture site is most common is cornua, as you can see, left and right in this common incidence. The lower segment and the fundus is lower incidence of as a site of rupture. Now coming to the diagnosis, golden rule is uterus rupture is a clinical diagnosis, and therefore must have a high index of suspicion. Uterine rupture should be first ruled out in all pregnant women presenting with acute abdominal pain, regardless of the gestational age. So I think once of and suspect rupture, besides academically, yes, there are investigations that can be done, but usually we don't have time to do the investigations like confirming the diagnosis in the form of CTG by finding out the fetal distress, image baseline uterine pressure and loss of uterine contractility. Similarly, radiographically, it can be diagnosed with the ultrasound, MRI in uterine pressures. And very careful that the ultrasound, they say that the test greater than even 4.5 has a negative predictive value of 100%. But unfortunately, the positive predictive value is less than 3.5 is poor, 11%. So one has to be, ultrasonographically suspecting an unscarred uterus is very, very difficult. Yes, after the rupture, it can be identified with a protruding amniotic sac, maybe a linear defect in the form of an anechoic line can be seen. Uterus is empty with gas bubble. The fetus is lying in the peritoneal cavity. There may be uterine hematoma and free fluid in the peritoneum. MRI. These are very quickly, if we don't, when the patient we don't have time to do all these investigations. MRI is a very good radiography. This is, is really not possible except when it's an incomplete rupture and a rupture which is very, very clear. This things can be seen on the images. The pressure catheters were used in the past. They are new as they are contractile. That is lost with the loss of. Now, on to what should be the management and coming on to the threatening uterine. Find you can see that the uterus has not ruptured and it is going to rupture. The important thing is to do immediately as it is a section, because then you can save the mother. But this situation is as such the uterus is rare and this condition is rarest of the things. But if one is lucky, yes, one should immediately do a section. Now coming on to the management of uterine rupture, which is already basic principle is that there should be intensive resuscitation. Things have to go simultaneously, the resuscitation and the operation to be done in the same, at the same time. So the intensive resuscitation, emergency and broad spectrum antibiotics and adequate post-operative care is a must when we want now. Resuscitation, as we know, that we need to correct anemia by giving intravenous fluids, and intravenous broad spectrum antibiotics has to be given for the infection that can occur, and they should not be delayed. The moment you find that the patient is fit for anesthesia, the patient should be, put on the operation table to be taken care of. So basic principles of the management are that the uterine repair is effectively or if restrictively may be indicated. And it's only when the hemorrhage persists, either the hysterectomy that can be done are either total or subtotal, and it depends upon the site of rupture and patient's condition. In regarding a thread or not, so which one is durable, which will not result in rupture in the next pregnancy. So there is no evidence that is there to of lateral rupture involving low uterine segment. Sometimes, involving the uterine artery, it is possible that one may have to do the ligation, ipsilateral ligation of the hypogastric artery. And if the uterine repair has been achieved, which is important, if the tubectomy has not been done, then the patient should be warned very carefully that there are chances of repeat rupture in 20% of cases in the next pregnancy. These are the points that should always be taken into to be kept in mind. Then, say, exploratory laparotomy with delivery. It's something that if one can do it within 10 to 7 minutes of rupture, one can save the fetus. Otherwise, the fetal morbidity and mortality is much higher. The laparotomy and the surgical management depend upon the type of uterine rupture. Degree of the uterine rupture, amount of damage that is occurred, edge of the rupture, ragged or irregular, general condition, others desire for future childbearing. We have certainly, there are basically the and the management. Definitive management is restrictive. Can be total. The conservative management can be repaired only and can be either repaired with sterilization, hysterectomy that is to be done. Conservative management, as we know, uterine repair should be reserved for women who have the disease of future childbearing. Low transverse cord to the broad ligament, cervix, or paracarpus. Early control-label uterine hemorrhage, general condition, and no clinical or laboratory evidence of coagulopathy. These are the basic requirements if one wants to save the uterus. Definitive management, as already said, is especially intractable uterine bleeding is there, and the sites are multiple, longitudinal, and low-lying. Now, all these things should be done after the hysterectomy and the repair has to be done. The patient may have operative complication in the form of infection has to be taken care of. The damage to the uterus one should see before, because sometimes the hematoma is so huge that one may not be able to identify the uterus before putting on the clamps. They are very, very careful as far as the output is concerned in the post-operative period. There are chances of amniotic embolism. There are chances of maternal hemorrhage, massive, in the morbidity of the disseminated intravascular coagulation because of the extensive hemorrhage, and there can be pituitary failure because of the that can occur. So the prognosis, as we know, of the rupture of the unscarred uterus it is associated with infant perinatal death, maybe as high as 6%. And women with uterine rupture require an emergency hysterectomy. Case may go high as happens total case representing. And it has been in a Dutch national wide there was no pregnancy in maternal death there, but perinatal death was 8.7. So the chances of the fetus being lost is much more as compared to mother. Mother also the life is threatened. The outcome of the that the death uterine rupture is not uncommon. Mortality and higher uterus rupture
मैम कितना इसका था
mortality
सर?
15.9.
Yes, sir.
Coming on to the conclusion, ruptures are rare but catastrophic and critical complications with an overall incidence of 0.07%. Diagnosis is clinical and should be suspected. Requires an intensive resuscitation. Surgery is mostly definitive. Indication for repair with or without tubal ligation to be done. Definitive indications and proper counseling as there are chances of recurrent rupture in the next pregnancy. So I would like Happy New Year, Bhartiya Navavarsh ke Mangal my कामनाएं and thank you. So I say thank you to all of you for the patient hearing.
Over to you, chairpersons, to please conclude.
Yeah, hello. Yeah, am I audible?
Yes, ma'am.
Yes, ma'am.
Yeah, thank you so much, doctor. Although the voice was not clear, but the every slide was so self-explanatory. I think nothing to ask much. And thank you so much. And I heartily congratulate to team Happy Learning. और आप सभी को नए साल की शुभकामनाएं और आप सभी को मेरा राम राम.
Thank you.
The voice is here.
Diagnosis, early diagnosis is very much important. Once we diagnose, immediately we can treat. It's very important that you said, because time interval, we should not waste time. So time interval should be very, it's precious. Once we diagnose it, immediately we start our treatment. Whether it is surgical, because everybody knows surgical treatments, even once we open the uterus, open the cavity and we see the type of uterus, immediately we have to take a decision whether patient needs repair or she needs immediate hysterectomy, because life is more important. So first, immediately diagnosis and management is required.
मैम आपकी आवाज चली गई है. नीरा मैम आपकी आवाज चली गई है.
Is it audible?
अब आई.
No, I was just telling the slides were really good because uterine rupture, immediately, because we have to diagnose it and then only we can treat it. Because so diagnosis, early diagnosis is very much important, and immediately once we take our patient to the OT and we open it, immediate decision is required because we have to save the life of patient. So if we need hysterectomy, immediately we have to take for decision for hysterectomy. If we can, that patient can be left for uterine repair. If she does not have, it's a first pregnancy, so we have to immediately decide what is to be done. Because if we don't decide immediately the treatment option, so the life of the patient is more important. So decision and treatment is required immediately. Thank you, Manjuji, for such a nice slides.
Thank you, ma'am. Thank you, Manju, ma'am. Sir, may we start the...
Oh, yes. Oh, yes.
Excuse me, ma'am. One point to stress upon that in these cases, in obstetric emergency, life-threatening emergencies, resuscitation, one has not to wait for adequate resuscitation. Resuscitation and definitive treatment has to go together. Because in obstetric emergency, one has not to that adequately resuscitate, then to go for definite resuscitation, definite treatment and all. So both has to go simultaneously in obstetric emergency, as far as I feel.
Yes, Dr. Agarwal, I have already said two things have to go hand in hand. The moment a person is able to be fit for anesthesia, the patient should be done a laparotomy immediately.
Welcome everyone to this reverse panel on legal issues in labor and sudden obstetric collapse. It's a reverse panel. The expert is MC Patel, sir, and I, Dr. Asha Jain, am the moderator. I would like to welcome MC Patel, sir. He is a consultant obstetrician, gynecologist, and medico-legal expert. He was VP Foxy in 2018, organizing secretary of AICOG 2017. He was the chairperson of Ethics and Medico-Legal Committee Foxy 2011 to 13. And as Naren Malhotra sir so rightly said, he is there for every Foxian at one phone call. So there are a few qualities that sir has, which is his dependability, his accessibility, and the persistence with which he does things. And also, he's been doing it continuously for 188 episodes. When he's going to the villages in the Northeast to serve women, he's doing it for 21 years continuously. So with these qualities, he would make a sustainable difference in Foxy is what I feel. So welcome, sir. And that's me. And I would like everyone to hear a short video appeal from sir.
शुभं करोतु कल्याणं आरोग्यं सुखसम्पदम्.
Respected seniors and dear colleagues, serving Foxy for years together on this auspicious day with folded hands and down head, I seek your guidance, blessings, and support to endorse my candidature for the post of Foxy President year 2026, election year 2024. Consistently working for Foxy and trying to visit even a smaller societies and to assist our common Foxian friends in any given situation, I have tried to serve Foxy. I assure to serve Foxy in the same way with the same zeal and enthusiasm. पथ का अंतिम लक्ष्य नहीं, सिंहासन चढ़ते जाना, लिए सभी को साथ, आगे है बढ़ते जाना.
So I would like to make an appeal on Sir's behalf to endorse his candidature for President Foxy election year 2024. And this is an appeal from me for support for Food, Drug and Medical Surgical Equipment Committee Foxy election year 2024. Nominations will be in May and election will be in August. So requesting, please do support us, nominate us, and also vote. So now we proceed to the panel. We have 14 panelists, and I will be taking the introduction of each panelist as their question comes along. One request is, if some panelist is absent, then somebody from that same place to please take that question. So, sir, as I always start, I'm asking you, is it even worth discussing? Because when it's an emergency, there's a collapse, then there's not much that anybody can do. So is this question worth discussing?
It is always worth to discuss, because as far as medical legal consequences are concerned, they are increasing in number constantly and steadily in India also. And if we go with some statistic related to USA, then almost 78% gynecologists face medical legal issues once in their lifetime, and 37% face situation more than thrice. And as far as Indian scenario is concerned, gynecologists rank first as far as number of medical legal situations are concerned. So if we go with statistic related to medical legal issues cases in different courts, that with any situation, normal, abnormal, emergency, critical, whichever, but we should be very careful about proper counseling, proper documentation, and representation of our service given to the patient in court of law. So nowadays it has become very important for discussion. And whenever something goes wrong, as far as morbidity or in few of the cases mortality is concerned, whether maternal or fetal, it becomes very difficult to explain to the relative many times. And that is why we have to understand this, how to deal with this situation in those conditions. So it is very much needed as far as discussion related to medical legal problems are concerned in our day-to-day practice.
Thank you, sir. So first we have Dr. Garima Trivedi ma'am, who's Director of Ma Bhagwati Mother and Child Care Center at Prayagraj. She has an advanced ultrasound training and has a lot of academic interests. But other than academic interest, she likes traveling, music, and dance. So,
Thank you, ma'am.
Yes, ma'am. Over
Ma'am, my question to the sir is, why litigations are commonly related to pregnancy and labor? Is there any case related to this, sir?
As far as litigations related to pregnancy is concerned, usually they are with young patient, because of course there are very few cases where advanced age is also there, but usually they are young patient, and usually they are book patient. Of course, there in few of the conditions they could be emergency patient, unbooked patient, but usually they are book patient, and usually they come on foot, because of course in few of the conditions they may be brought in emergency in ambulance or in stretcher, but otherwise they come on foot. Young patient come on foot, book patient, and naturally we are dealing with two life, mother
Yes,
and fetus,
and the baby.
and relative and patient herself considered it to be a very physiological phenomena rather than pathological phenomena. So they are not ready to accept any adverse outcome, morbidity or mortality. So these are some common areas as far as this litigation part is concerned. And as far as cases related are concerned, there are so many cases decided in court of law. Of course, whenever they are based in court of law well by our doctor friends with a document about treatment given in that given situation, cases are decided in favor of doctors also. But we have to face this type of situation in obstetric mishap, particularly when something goes wrong.
Thank you, sir. Well
Yes.
explained. Thank you, sir.
Thank you, sir. Next, we have Uma Jaiswal ma'am, who's the secretary of Prayagraj Obstetric Gynec Society. She does painting and her current love and hobby is cosmetic gynae. So over to you, Uma ma'am.
Thank you, ma'am and sir, for having me over here. My question to sir is, which are the areas for litigation and which are the assisted obstetric situation which may lead to litigation?
So usually, as far as area related to litigation during pregnancy or labor is concerned, common allegations are it was delayed in diagnosis, not investigated properly or not managed properly. It was wrong diagnosis. No proper counseling and consent was taken related to staff infrastructure. Then many times now it has become one more allegation, unnecessary investigation. And then emergency services were not rendered properly. Proper communication was not on part of doctor and hospital staff. Delayed in transfer. If at all we have to transfer patient to higher center for further intensive care. So this is also one more allegation why patient was not transferred well in time, so that a hospital where patient is transferred can have enough time to manage the situation. As far as some complications are concerned related to pregnancy or related to labor is also one more area, morbidity, maternal or fetal, and in few of the cases mortality, fetal or maternal, and some complications related to pregnancy or this labor, trauma, injury. Just we heard Dr. Manju madam about this rupture of uterus. So any obstetric injuries, they are also becomes area as far as litigation is concerned. And as far as some procedures related to our pregnancy or this labor part rather. So whenever we are go for instrumental delivery and some complication related to that, or operative delivery and some complication related to that. So these are the areas as far as litigation is concerned.
Thank you, sir. It's very well explained. Basically, we have to take a detailed, informed consent.
Yes.
That is more important.
Proper consent and proper documentation is the answer.
Answer. Thank you, sir. Thank you very well.
Thank you, sir. Now we have Dr. Mridula Sharma, ma'am, who's the president of Bareilly Obstetric Gynec Society. And she likes to dance. She's taking formal Kathak training. And that is what she utilized the COVID times for. So over to you, Mridula, ma'am. She was also a national level hockey player, but this is her new love. Mridula, ma'am.
Thank you. Yeah, I'm here. Good evening, everyone. And I thank Patel sir and Dr. Asha for including me here. Regards to all the seniors over here and my good wishes to the colleagues. And I see a few friends. I mean, all are friends, of course, but I see a familiar faces also over here. So hello, Vidya, and I can see ma'am, Manju ma'am here. And so my question, Goel sir also, I can see. Good evening, sir. My question is, this was a case that happened way back in 1995, and this is regarding baby Ramya versus Dr. Aruna Reddy. The facts of the case are that it was a forceps delivery, delivered baby of about 4.5 kg vaginally, and the baby unfortunately developed brachial palsy. The case was filed. Defense on part of doctor was that it was a complicated case and the patient refused for consent for cesarean, as we usually see it even today. And as the baby was getting asphyxiated, the doctor applied the forceps, conducted the forceps delivery. So the inference held by court was that when the patient was admitted at 6 a.m., the delivery started at 4 p.m. There were no investigations, no sonography, no evidence that consent was refused, and that doctor was slapped with a penalty of about 1.7 lakh in 1995. So, sir, my question is that where things went wrong?
So, three things in this case. Baby was 4.5 kg. And when we are planning to deliver 4.5 kg baby vaginally, it should be well explained to the patient and patient party a complication related to deliver this big baby vaginally. When baby was getting asphyxiated and when cesarean section was advised, they refused to give consent for cesarean section, which doctor had taken defense at the time of this facing this case. But he couldn't produce in court of law negative consent. If patient or patient party are not ready to give consent, then we have to take negative consent, that we were explained that baby getting asphyxiated and cesarean section is needed, but we are not giving consent. This type of negative consent is equally important, because if patient and patient party do not follow our instruction, then it becomes contributory negligence on part of patient and patient party, and it becomes good defense in our favor. But it should be well documented, and we should be in a position to prove it. As far as one more inference held by the court was then that baby, patient was admitted at 6 a.m. and delivery happens or started at 4 p.m. So no investigation in between were advised. So in this situation, whenever we examine patient, even before delivery, when patient is waiting in labor ward or so, then each and everything should be entered in case paper seen by Dr. So-and-so, date, time, findings, and if at all we have advised anything investigation wise, then also, and whichever treatment we have advised, and it should be reflected in nursing chart also, because whatever you advise in your case paper, but whether it is executed or not can be decided by nursing chart also. So all these points were lacking in this case. Otherwise, this case was not to be lost, because it was good case to fight in court of law. But unlucky on part of that doctor, she lost that case, and compensation of 1.75 lakhs in those 1995. At that time, this was very big amount. It was awarded to
Huge
patient
amount.
party. Yes, next.
So, sir, proper consent and proper documentation are
Yes.
must.
Yes.
And that is
And
that all of us should realize that.
Yes. One good part is anticipation or foreseeability. When you are going to deliver 4.5 kg baby vaginally, then you should anticipate which kind of complication you may likely to face. And it should be well explained before this delivery happens to the patient and patient party. At the time of admission only it should be explained. And at the time of explanation, at the time of admission, we should explain that we may have to switch over to instrumental delivery or operative delivery if situation turns accordingly. So if we have explained well in advance, and if they are mentally prepared, then it becomes little easier one to get consent if at all cesarean section or any intervention of instrumental delivery is required. So anticipation is equally important.
Thank you, sir.
Thank you, sir. Best wishes. And
Thank
we
you,
look
madam.
forward to seeing you at Bareilly.
Yes, I am there on 21st.
Yes, sir.
So thank you, sir. Thank you, Mridula ma'am.
Thank you, Dr. Asha.
Now we proceed. We have Dr. Gayatri Singh ma'am, who's the secretary of Bareilly Obstetric Gynec Society. And what she loves is singing. I could not cut the video I received. So this is ma'am loves singing. Over to you, Gayatri ma'am.
Yes, Gayatri madam.
I
Is she
can't
there?
see Dr. Gayatri here.
Then anybody else from
Since she's
Bareilly?
also from Bareilly, she's secretary
Okay.
of our society.
Yes.
So
Yeah, please take the
can I take up this?
Yes, anybody from
Yeah.
Bareilly can.
Yes, please.
So this is another case, Neena Gupta versus Deep Nursing Home, again way back in 1996. And this was, the facts were forceps delivery, a uterovesical fistula, defense on part of doctor occurred during process, inference held by court that the doctor is liable. So where things went wrong, sir?
Again, same. Whenever we are going to deliver patient by intervention by any instrument, whether it is ventuge or whether it is forceps, then again we will have to explain well in advance in detail that what could be the consequences related to forceps delivery, which could be the probable complication. And many a time, whenever this uterovesical fistula or any injury occurs, they will correlate that it is due to forceps delivery only. But many a time when it is a prolonged labor and head is stuck up at some junction for longer time, due to pressure necrosis, this type of fistula may occur and it may end up after 3-4 days or so. So it is not necessary that it could be due to injury related to forceps delivery or so. But prior consent and proper counseling in this type of instrumental delivery is equally important, so that whenever we have to face this type of case in court of law, it becomes good defense. And for that, I would suggest to visit Foxy website. And on Foxy website, we have prepared 30 different consent, and it is available with uniform Foxy uniform consent with 3 medical legal experts, Dr. Dilip Walke from Pune, Dr. Nikhil Datar from Mumbai, and myself, Dr. MC Patel from Ahmedabad. We have prepared 30 consent, and we have prepared consent for this also, instrumental delivery or cesarean section, or we have prepared consent for normal labor also. So you can visit Foxy website, you can download those consent, and you can use in your day-to-day practice. So how to counsel patient, how to take consent, everything is written in those consent. Yes, next.
Next, we have Dr. Latika Agrawal, sir. She is also she's been a gold medalist, has a credit to many papers published. She works at Sarthak IVF Center. She does sketching.
Good.
So over to you, ma'am. Latika, ma'am.
Welcome. Welcome, Latika. Is she there? Has she joined?
No,
Because
sir,
she is
can't
very
see
busy
her.
with UP
Can't see her, sir.
Yes, so she is very busy with UP. So anybody from Bareilly can take, no issue.
Yes, sir. I think I come back with the question
Yes.
again.
Yes, you can take
Madam
Mridula.
Neera is also
Yes.
here. So Neera
No,
ji,
no,
aap
no.
puchiye. Please.
No. You can continue. Okay.
So
Continue.
the question is, which injuries are more likely to cause litigation?
So
The
as
birth
far as
injuries, the birth
yes,
injuries.
yes, as far as birth injuries are concerned, naturally we will divide into two parts, whether maternal or fetal. And as far as maternal injuries are concerned, perineal lacerations, or many a time third degree perineal tear, or which may call it complete perineal tear. So when obstetric anal sphincter injuries are there. These are some areas for litigation, because many times if she has incontinence or so, then it will lead to litigation. Other injury related to a para-urethral part or urethral part and bladder injury and leading to fistula, just we discussed in last case also. Cervical injury, rupture of uterus, whether repairable or non-repairable, and if you have to go for obstetric hysterectomy, and if he is primary patient, then it becomes very difficult to face this type of situation. And VVF or RVF. So these are some areas as far as maternal injury part is concerned. As far as fetal part is concerned, naturally birth asphyxia is the main cause, and ultimately it may lead to some other complications also. A fracture of bone, particularly clavicle or long bone, or herb palsy and CP in future. Then injury during cesarean section, because it is very rare, but just due to knife cut on body of a fetus. So these are some areas as far as injury is concerned. And sudden perinatal death, fetal death, is also one of the area as far as litigation are concerned. And whenever baby goes with permanent disability due to this birth injury, then it becomes a potential situation as far as litigation is concerned. Say, for example, if patient goes CP, then it is very difficult for us also in court of law. Of course, we can prove whether it was antenatal region, whether it was during labor, or it happened after delivery. So we can have a defense in these cases also. And in few of the cases, court has given judgment in favor of doctors also. But it depends how you defend your case. Yes, next.
Dr. Patel, just
Yes.
one thing, in case of speech presentation, one should be very cautious, because in we have to follow all manners, because once lighter is very less in the take of baby in this presentation, sometimes there are chances of birth injury. So in that case also we have to counsel the patient.
Yes, naturally. So we should be careful at the time of counseling patient. And I would
Yes.
like to mention one case which happened in South India. It was C. Jaipal Reddy versus Padmini Veluri. And this case was decided in National Commission. And National Commission has very specifically mentioned that consent is not mere piece of paper where patient or patient party has to sign. It is an important document of your counseling, your communication. So whatever you counsel, whatever you communicate to the patient related to your treatment plan and situation of that very patient is very important. So whatever you counsel, whatever you communicate, each and every point should be mentioned in that consent paper, and then patient has to sign. So if you have counsel patient well, then it becomes good defense in your favor.
Thank you, sir.
Yes.
Now we have Dr. Pratima Mittal ma'am from Bulandshahr. She is not here. I did not see her in the list. She
So
likes
anybody from
singing.
Bulandshahr?
Dr. Indu was, I saw Dr. Indu from Bulandshahr.
So the Indu madam can take, no issue.
Indu ma'am, would you like to take this? Dr. Indu? I think anyone can take this,
Yes,
please.
anybody can take, no issue.
Hello, everyone. Good evening. So my question to sir is, sir, we are all afraid of the term negligence. So what is negligence exactly, and what are the types of negligence?
So in our curriculum during second MBBS in forensic medicine, we were taught two words, omission and commission. Act of omission means not to do something which a reasonable prudent doctor would do. Say, for example, if we have to go for injection penicillin. So any prudent doctor will go for negative test dose, and if at all test dose is negative, then only he will give full dose. So if we give penicillin without a negative test dose, and if something goes wrong, then it becomes an act of omission. Act of commission means doing something which reasonable prudent doctor would not do in that given situation. Say for example, if you have planned cesarean section and if you have planned under general anesthesia, for any reason general anesthesia is planned and patient has come with full stomach. When it is planned surgery and patient has come with full stomach and general anesthesia is to be given, then if at all you go with general anesthesia and if something goes wrong, then it becomes a act of commission. So this is very clear. As far as negligence is concerned, there are 4 ingredients of negligence. First is legal duty. As soon as you accept any patient to treat, it becomes a contract or implied contract between patient and yourself. You are offering your services and patient pays for that or patient promises to pay for that. So as soon as you accept any patient to treat, your legal duty starts at that point of time. One more ingredient is breach of that duty. So for any reason, if you breach that legal duty to treat that very patient, then it becomes one more ingredient. And the third ingredient is damage suffered by patient. So if patient has suffered some damage, then it becomes one more ingredient of negligence. And very important part is action of doctor should be direct and proximate reason for that damage suffered by patient. If prosecution can prove all those 4 points, then only negligence can be proved. Negligence could be of 2 types, civil negligence and criminal negligence. As far as civil negligence is concerned, usually patient or patient party go with litigation to have a compensation in term of money. As far as criminal part is concerned, then they may go in police station or in criminal courts and they may lodge complaint as far as criminal negligence is concerned. But to prove criminal negligence against doctor is very difficult because to prove criminal negligence, negligence should be gross, because in one of the case Supreme Court has come up with this guideline that there should be gross negligence on a part of treating doctor and it should be high standard of recklessness, then only criminal negligence can be avoided. Otherwise civil negligence patient may go for. And as far as this litigation part is concerned, as far as civil litigation is concerned, patient may go in civil court or patient may prefer litigation in consumer forum courts also.
Thank you, sir. Thank you for the explanation, sir.
Hello. Thank you, sir. Next, we have Indu Singh, ma'am. So she is having some problem with her PC, sir. She is here, but she is finding it difficult to speak. So, Indu, ma'am, you can speak.
Yes, I'll try, ma'am. Am I audible? Good evening.
Yes, you are audible.
Yeah.
Yes, go.
Good evening, sir. I would
Yes.
like to ask, sir, what is the importance of consent? And is consent necessary in case of normal labor also?
Just we discuss little as far as consent is concerned. It is very much important because without consent, you cannot touch even. As far as legal part is concerned, without consent, you cannot examine you. So consent is very important part in our day-to-day practice. And as far as normal labor is concerned, usually it is not routine. In our day-to-day practice, we never go for consent. Delivery is required, only we go with consent. But it is always, sorry, advisable to go with a consent for normal labor also, because we never know. Even normal vaginal delivery may end up into some complication. Just we mentioned prior also, a complete perineal tear. And when we have to suture that tear under anesthesia, then it will be difficult for us to explain to the patient. So if we have taken consent for normal labor at the time of admission, or we may explain everything related to normal labor, probable complication, probable outcome of labor, how labor can progress, instrumental delivery may require, operative delivery may require. If we have explained everything and probable complication related to that in that very consent, each and every point if we have mentioned, and if patient has signed the document, it becomes good defense in our favor.
Thank you,
Yes,
sir.
ma'am? Yes.
Thank you. Now we proceed to Dr. Poonam.
Yes.
So she is the president of Firozabad Obstetric Gynec Society. And when I asked about, hobbies, I got the first one who said to enjoy party. So
Very
welcome,
good.
ma'am. We'll have some party with you someday.
Good.
Over to you, ma'am. You're muted. You're muted.
Thank you, ma'am. And good evening, sir. My question to you is, sir, that we obstetricians are deal with so many emergencies and we are so busy in our OPD and IPD. Then what is the importance of record and how should we manage to maintain it? And how should we manage to give the discharge card properly so that we can avoid litigations?
Yes. So naturally, record is the very important part, and as far as our defense in any case in any court is concerned, we can prove ourselves by record only. So whatever we did for that very patient, it can only be proved by record. So records are always at your rescue. So keep them up to date. What was done? Nothing was neglected, and given treatment should be matched with standard demanded by ethics and law. So we should treat patient as per standard protocol, standard guideline, and how it is decided. It was standard treatment. So standard treatment which is given in standard textbook. So court takes references of this. So in that very given situation, what textbook says how patient is to be managed. So if we have managed patient that way, then it becomes good defense. Second part is practice prevailing in nearby medical college. So how in that very given situation, medical college people would have treated the patient is also considered. Third part is some references of journals and some guidelines, say for example, guideline from FOXI, guideline from ICOG, guideline from RCOG. So this type of guideline can also be at our rescue if we have treated patient accordingly. And one more part is references. We may have reference if you are facing any litigation, we can have reference with senior doctor of our stature. Then if he or she says that whatever treatment was given was as per standard medical norms, and if this case would have been to me, I would have treated this in same way, then it becomes good defense. So this is importance of record. As far as labor part is concerned, partogram and CTG tracing, it is also part of our record. Purchase of emergency drugs or routine drugs is also part of our record. Say for example, oxytocin, ergometrin, prostaglandin, carbetocin, whichever drug we use, we should have bill to prove that it was available at the time of delivery. It is very important part. And whatever record we prepare, whatever record we produce in court of law, it should be easily acceptable to the court. Because many times what happens when we are facing litigation, we prepare record up to date. But if smart advocate on part of prosecution is there, then he will ask, doctor, can you produce record of co-patient or patient 1 month back or so? And if you have not maintained record in the similar fashion, then court will interpret that this is manipulated record or you have prepared record for that case only. It is not your routine practice to maintain record. So we should have habit to maintain record as far as important parts related to records are concerned. As far as discharge card is concerned, so a discharge card is mirror of our treatment given. So naturally we go with a detail of patient name, age, address, fine. Provisional diagnosis. And if you have come to final diagnosis, then final diagnosis, all the investigations which we have advised and done, it should be mentioned. Of course, we cannot mention everything in discharge card. Then we can mention that all the investigation were done, reviewed, and it is given to the patient. So it should be mentioned in discharge card that way also. As far as treatment part is concerned, at the time of discharge, we have to advise about follow-up, where patient has to come for follow-up, about diet to be taken, about medicine to be taken, about exercise, and references. If you have refer patient or if you have advised to have reference for another specialty or another colleague, then it is to be mentioned in a discharge card. And I would like to quote a case which happened in state of Tamil Nadu. One more case happened in state of Gujarat also. So in that case of Tamil Nadu, it was premature delivery. Baby was admitted in NICU and in due course baby was discharged. But at the time of discharge or during course of NICU treatment, nobody advised parents to go for opinion from ophthalmologist to rule out retinopathy due to prematurity. And in that very case, baby ultimately went blind. Case was filed and compensation of 1.8 crore was awarded to the patient and patient party. It happened in government hospital of Tamil Nadu. So 1.73 crore was to be paid by government of Tamil Nadu and rest of the amount was to be paid by neonatologists who attended baby in NICU. In this case, luckily, gynecologists were not made party. So these are very important points as far as discharge card is concerned. And one more part, I mentioned about important bill of purchase, but refilling of oxygen cylinder bill is also equally important, because in one of the cases there was allegation that when patient suffered heart attack, oxygen cylinder were empty, and it happened in the state of Gujarat only. But we were saved in that very case because we could produce bill of refilling of oxygen just 1 day prior of this incidents happened. So bill of refilling of oxygen cylinder is also part of your record and it should also be preserved. Yes, next.
Thank you, sir. Sir, I want to ask one more question.
Yes,
That in
yes,
first
yes.
trimester, sometimes we have to do emergency surgery, and in this case, sometimes patients wants to continue the pregnancy. And if the patient develops any congenital abnormality or something like complication, then is it patient may litigate for this to the
So
surgery or
it
not?
is very simple. If for any valid reason or valid indication, if you have advised to terminate pregnancy and if patient is willing to continue, then at that time of point of time, proper counseling and consent on part of patient is very much important. So patient should have given consent that everything was explained to me related to probable outcome of baby as far as anomalies are concerned. And even after all this counseling and consent, I have decided to continue pregnancy. And whatever consequences happens due to continuation of pregnancy, hospital staff or doctor will not be held responsible. So if we have taken consent like this, it becomes good defense in our favor. And this becomes non-compliance on part of patient. When you advise something and if patient or patient party doesn't follow your instruction, then it becomes contributory negligence on part of patient and it becomes good defense in your favor. But burden of proof is on your shoulder to prove, so it should be well documented. Yes, next.
Thank you, sir. Next, we have Garima Sharma ma'am, who's the secretary of Firozabad Society. We've already met her here. So over to you, ma'am.
So, sir, my question is about a patient who was admitted with labor pains. She was in good health at the time of admission, but because of unsatisfactory progress, cesarean section was advised. Patient and relatives were reluctant to give the consent, and the doctor was constrained due to non-cooperation from the patient side. And he emphatically warned the attendants, including the patients, either to consent for cesarean section or to take the patient to any other hospital. After about an hour, the attendants gave consent for cesarean, but now they are asking for guarantee of mother and baby. Now what should be done, sir?
So this is usual scenario in our day-to-day practice.
Yes, sir. Most common scenario.
Yes, when cesarean section is indicated, and we explain that now we have to switch over to surgical interference and cesarean section is very much needed. Usually, if patients are well convinced, then they give consent. But in many of the situations, they will have an excuse that her husband is not present, he is coming. When he will come, then we will give consent. And many a time when it is an acute emergency related to birth, fetal asphyxia or so, then we have to switch over to deliver baby immediately. So here comes role of consent again, negative consent. If patient is not ready to give consent at that point of time, it should be mentioned, and we should have a signature of patient. Many times patient will refuse to give signature and patient party will also refuse to give signature. So in this situation, you can have signature of any co-patient or any visitor of a hospital that it was explained before us, but they were not ready to give consent. So if at all something goes wrong, then it will be good defense in our favor. In this situation, in this particular case, after some time, after 1 hour or so, they were ready to give consent, but they were asking for guarantee. We cannot give guarantee ever. Nobody can give it. We can give guarantee of our best efforts. But as far as result is concerned, we cannot give guarantee because when it was indicated, they didn't give consent. Precious time of 1 hour is wasted, and now condition could be different one. So if you can give guarantee, then it will be difficult for you to face if at all something goes wrong. So if they have not given consent well in time, and if they are ready to give consent afterwards, and if you are proceeding accordingly, then again you will have to explain that you have given consent after this period. Now I will try my level best, but I cannot guarantee about all good. So you have to explain that also, and it should also be entered into record, and they should sign the document, because whenever they give consent and sign the document, this line should be explained that as such, cesarean was advised 1 hour prior or 2 hours prior or so. They didn't give consent, and they are giving consent at this point of time. So in that very consent, it should be mentioned that we were explaining about consent, we didn't give consent, and we are giving consent just now. We have been explained everything related to probable prognosis, probable outcome, probable complication. If we have taken consent like this, then it becomes good defense in our favor.
So for this patient, a cesarean section was performed and an asphyxiated baby with very low Apgar was delivered. Baby had convulsions. After some time, it was intubated and shifted to NICU. Attendants now blaming the doctor, saying a false hope of normal delivery was given, wrong medicines were given, fetal heart was not checked during the labor. One injection was administered which stopped the pain for some time, and then created situations so that complainant was compelled to give consent for low segment cesarean section. So, sir, how to protect oneself in case of such litigation?
This is also very common situation, because common doctor didn't give proper attention. Doctor didn't examine for fetal heart. This is very common, and we can prove it by our record only. That whenever we see patient and whenever we have heard fetal heart, it should be entered into record. Date, time, fetal heart, say for example 160 per minute, regular or whichever. So if we have mentioned in everything in record, then it becomes our defense. As far as this wrong medicine is concerned, whichever medicine we have given to the patient, It is well recorded in our document, and of course they can challenge whether this medicine was proper to be given at that point of time. But we can prove in court of law whatever we gave as far as medicine is concerned, or whatever treatment we gave, it was as per standard medical norms. It is not that difficult to prove in court of law. And this allegation that doctor gave some injection which stop the pain, and they make a show that cesarean section is very much needed. But this type of allegation doesn't stand in court of law, because whatever we can produce by our record, how we have managed that very patient in that very given situation, becomes our good defense. So nothing to worry for this type of allegation.
Thank you so much, sir. Thank you.
Thank you, sir.
Yes.
Now we have Dr. Sanjaya Sharma, ma'am, and she's the past president of Jhansi Obstetric Gynec Society. I did not see her here, so I would request somebody, Alka ma'am, if you are here, if you would take
Yes,
this.
Alka madam is there. So Alka madam can take. Welcome, madam. Alka madam.
Hello.
Yes. Yes, Alka madam.
Requesting anyone here to please take the questions.
Anybody from
I will
Jhansi?
take, sir. Yes, sir, I
Yes.
am here. Dr. Vidya is here.
Yes, yes, Vidya, you can.
Alka madam was there. Okay, okay, sir. Continue the situation. Baby safe but developed the cerebral palsy. Now the attendants filed a case against the doctor. How to deal such situation and how to counsel such attendants and how to handle this litigation.
So in this case, when they were explaining about need of cesarean section, and they didn't give, because at that time, if we have recorded in our case paper that it was asphyxia and cesarean section was very much needed, then it becomes our good defense. Because to develop cerebral palsy with baby, so whether it was region was antenatal, so before it happened before delivery, or at the time of delivery something went wrong, or after delivery. So if they have not given consent well in time, and if at all something goes with baby or mother, then it becomes good defense in our favor. So it is non-compliance on part of patient and patient party. And if we have documented well, and if we can prove in court of law, then we are safe.
वो कैंटीन में बैठी थी, वो लोग कोई बाबा जी के वगैरह कोई मंदिर वंदिर वहां जा रहे थे अपने बाबा गुरु
So
जी
next.
बैठी थी, वेट कर रही थी.
Thank you, sir. Hello. Now we have Alka ma'am, who's been the secretary of the society for a long time, and now she's the president of Jhansi Society. So over to you, ma'am.
Good evening, everyone. Thank you very much, sir, for the opportunity. And
Yes, welcome.
we all are very medico-legally very much vulnerable, so need your guidance all the time.
Yes, welcome.
well,
Always welcome.
Well, this is a case of a 32-year-old primary, full term. She was admitted with labor pains. There was no significant past medical history. So, to expedite labor, ARM was done and the LICA was clear. Patient suddenly developed cardiac arrest while in labor, was pulseless, and BP was not recordable. CPR was started immediately. So, a suspicion of amniotic fluid embolism was there. The patient was intubated and started positive pressure respiration immediately. The patient showed signs of partial revival. So my question is, what should be done? Should LSCS be done immediately as the fetal heart was present, or the patient should be shifted to ICU or a higher center. It's a real dilemma because we have to save both the mother and the baby. So, what is our preference and how should we go about it?
So, as far as sudden obstetric collapse is concerned, this is very typical case, sudden obstetric collapse during labor. So, it is always better to deliver patient immediately, and at the same time, rightly mentioned by Goel sir also, resuscitation should be continued, because whenever we face this type of situation, suddenly patient collapse, there is no pulse, no BP is not recordable. Naturally, we have to go for resuscitation. And as far as resuscitation part is concerned, if baby is delivered, then it will be this resuscitation will be much more effective. And perimortem cesarean section is also known in few of the condition. Of course, it is very difficult decision to take if patient is already expired, but this is the only way. And when pregnancy is more than 20 weeks, then we have to take a chance. If it is more than 28 weeks, then we have to take chance for both mother and fetus. So it is always better to deliver patient. No need to shift patient in NICU, because this is very precious time and you cannot afford time to waste, because immediate delivery could be the secret of success. And no need to shift patient in OT also. No need to go for anesthesia also. No need to go for antiseptic precautions also. Straight away you have to go for emergency cesarean section to deliver baby. If you can deliver baby in less than 3 to 4 minutes or maximum 5 minutes, then there are some chances as far as survival on part of mother is concerned. So as far as sudden obstetric collapse in this type of situation is concerned, resuscitation and to deliver baby is very much important. And legally also, you can prove in court of law by your records, whatever happened, it should be well documented chronologically and what you did. And in this situation, always shout for help. You should involve your professional colleague in this situation, because this type of situation cannot be managed alone. Because would you like to go for cesarean section or would you like to go for resuscitation? But if two people are there, then one will continue with resuscitation and another person will go with cesarean section to deliver baby. So to call for help in this type of situation.
Because time is very important. Time is precious in this.
Time is very precious.
Very
And in one of the case which happened in Riva, our own Foxian friend, Dr. Binu, she is now head of the department. In one of the situation, it was a sudden obstetric collapse. Patient was expired, and she took immediate decision and she delivered baby. And luckily, baby and mother both were saved. So of course, it doesn't happen in each and every cases, but what you did to save life of patient are taken into consideration in court of law, if at all we are facing litigation.
Right, very rightly said, sir. Thank you.
Yes.
Thank you.
Next, we have Dr. Vidya Chaudhary, sir. She is the secretary of Jhansi Society and loves cooking, does mehendi, craft work, all kinds of craft. So
We
after
will
me,
have to
this is
visit
one
Vidya's
person
place
who
when I
really
visit
showcased
Jhansi.
her food.
Asha, if she is fond of cooking, then at the time of visit to Jhansi, I would have to visit her place.
Most
Sure,
welcome,
sir,
definitely.
sure. Most welcome, sir.
Thank you, thank you.
This video, sir, it didn't work. वो देखिए.
Yes. Good.
So over to you, Dr. Dev.
Because in one of my visit to Jhansi, Alka madam was my host, and she is good host.
Yeah, madam is also,
It's
she
an
is very
honor.
good in cooking also.
Yes.
It's an honor to have you,
Okay.
sir.
Yes.
Thank you so much, Asha ma'am. So such a unique way of introduction with hobbies. And good evening, MC sir, for
Welcome.
including me in this happy learning classes, master classes. My question is if patient suddenly expire, so many times we are, I think everyone would have faced this situation if patient suddenly expire, how to handle the situation.
So in this type of sudden collapse, I mentioned prior also, call for help. And if you have a rush team in your society, you have to phone call to 1 or 2 person, and they will call to another person. Whosoever is available will be at your rescue in your hospital. And it is very important because many times when we declare this bad news to the patient, what is going to happen, we never know. So if at all you have apprehension, then you can inform police also, and then you can inform relative that whatever has happened, how this happened, what did you do to save life of patient, and you explain it. You subject in that very situation for postmortem examination to know exact cause of death.
So one thing I want to know, is it good to shift being in a private setup, it is better to shift in tertiary center?
So there are two situations. If patient is already dead in your hospital,
yes, sir.
Whatever efforts you can put, you should do at your hospital only. Because if at all you will sick patient, dead patient to another center, naturally that center will receive dead body, and they will declare that we received dead body or dead body was received. Now two questions will be coming to you have to face. That when you shifted patient, was she live or was she expired? If she was dead, then one more question, why you shifted patient if she was already dead? And if she was live, then was she in a hemodynamically stable condition to shift? You should at least resuscitate patient at that point of time. And if patient is little stabilized, then only you will have to shift patient to another hospital for further care. As far as dead patient is shifting is concerned, because very common allegation nowadays comes, and we on part of medical legal expertise we say it is easier to face case of negligence rather than case of forgery, because when you shift dead patient, then it becomes a case of forgery. You are cheating patient party. This is taken in that way as far as court's proceedings are concerned. So never transfer dead patient to higher center. Whatever efforts you can do at your place, you have to do that there only, and you have to declare death at your hospital only.
Okay, sir. Thank you so much, sir.
Thank you, sir. So now we are reaching the end of our program, and you have Dr. Rekha Singh, ma'am, who's the president of the Sultanpur Society. And, you know, she has dedicated her life besides her profession to her family. And here she is with her 90-year-old mother-in-law.
Very good.
So she takes really good care. So over to you, Rekha, ma'am. Rekha, ma'am, I can see you, please. Unmute yourself. Unmute yourself.
Yes, Rekha madam.
She's unable to unmute herself, sir.
She
I can see her, but
she's muted. Yeah.
रेखा मैम, जहां पर माइक बना होगा ना, उस माइक को टच करिए. जहां पे लाइन से म्यूट, स्टॉप वीडियो, सिक्योरिटी वगैरह सब दिख रहा है, आईपैड पे है. आईपैड में स्क्रीन के टॉप पे होता है मैम, देखिए.
She is Rekha Rajendra Kumar or someone else?
No, ma'am. She is Dr. Rekha Singh.
Rekha Singh, President, Sultanpur Society.
So she is not able to. Rekha Singh is not here.
Yeah, she's there. Kuchu Singh's iPad.
Kuchu Singh's iPad is her number.
Acha, okay. Acha, somebody is helping.
In the iPad, usually it gets hidden when your screen is on.
When we touch the screen, it will come, na?
Yeah.
In that lower side.
Lower or upper, it should come.
In MacBook, it is lower. iPad, I think it would be.
Or she
For
may
every
do
Zoom, I think Zoom में नीचे ही आता है.
log out and log in again.
No, sir.
It works.
No, sir, इसमें आ जाएगा. Somebody else can do it from here से नहीं.
Anybody from Sultanpur? Dr. Swati?
Yeah. Good evening, sir. Yeah, I'm here. I can take if
Yes,
she's
yes.
not able.
Yeah, please go ahead, Dr. Swati.
Yes, Swati Singh. Yes, welcome.
Okay. Sir, my question is, a patient is Gravida 2, Para 1, Live 1. And please.
Yes.
And she is with the previous cesarean and had planned a C-section. And now intra-op period, it was uneventful. No past significant medical history. Patient was planned for discharge on 4th post-op day. On 3rd post-op day, patient was taken for dressing. Suddenly, patient collapses, becomes cyanosed. CPR was started but could not be revived back. Cause of death was anticipated as pulmonary embolism. And sir, how to deal with this situation, like this emergency situation, and how to when attendants start creating a nuisance and all these things.
So same type of case happened in city of Ahmedabad only. In that very case, cesarean section was done. In due course, patient was discharged and patient was called for dressing. And when patient came for dressing, during dressing, something went wrong and patient expired. They tried all their level best as far as CPR part is concerned, but ultimately patient couldn't be saved. And relative created some nuisance. But in Ahmedabad, we have a rush team. Ahmedabad is big city, so in each area we have rush team. So that doctor called 1 or 2 gynecologists who are member of rush team. And you won't believe, within no time, almost more than 100 gynecologists at that hospital. I was one of them. We informed police. Police had been there, and police took the condition into control as far as nuisance on part of relative were concerned. And we advised for post-mortem examination. The relative were very reluctant not to go for post-mortem examination. They were not ready to go for post-mortem examination. But once we inform police, custody of body is with police, and that is up to police to decide to convince patient's relative. We have not to convince relative that post-mortem examination is necessary to know exact cause of death or so. So in this situation, when they were not ready, then police requested magistrate. It was middle of night, and you won't believe, magistrate came to the hospital, and magistrate had a statement before police etc. from relative that they were not ready to go for post-mortem examination. They had no complaint against hospital or hospital staff or doctor, and dead body was given to relative. So in this situation, here comes role of rush team, because if you are alone to declare bad news in this type of situation, when relative are very agitative to create nuisance, then it becomes difficult to face. So always involve your professional colleague, inform police, and manage the situation. As far as pulmonary embolism is concerned, because these are the potential cases for litigation also. If you have managed that very situation by police, by your friend at that point of time, but naturally they will go in court of law either for this compensation or for criminal case. So as far as pulmonary embolism part is concerned, in this type of situation, whenever you are facing litigation, you have to face certain questions. Was it preventable? And usually you cannot say no, because many of the complications are preventable. So one more question will come: what did you do to prevent it? And in spite of your all care and caution, if you couldn't prevent it, then why you couldn't prevent it will be one more question. Or one more question: did you diagnose that complication well in time? And did you manage that complication way in which any prudent gynecologist would have managed? So if you can answer all those questions, then you could be out of problem, even if ultimate outcome is death. Because ultimate outcome is not taken into consideration in court of law always, but your efforts to save life of patients are taken into consideration. And as far as pulmonary embolism is concerned, so the question will come: was she case of deep vein thrombosis also, or any thromboembolic phenomena? And if at all this pulmonary embolism happened, then what could be the reason of pulmonary embolism? If we can explain to the court, and if we can explain in that given situation, we have taken utmost care of patient to save life of patient, then we could be out of problem.
Sir, I have one question.
Yes.
Ma'am, Swati ma'am,
Yes.
just a second. We'll
Ma'am?
take 3 questions at the end. Okay?
Okay, ma'am.
Now Rekha ma'am has unmuted, so I would request her to take your question.
Yes, madam. Yes,
sure,
madam.
We have Dr. Swati and she does sketching. She's the secretary and she didn't send me any photo of her sketches. So over to you, Rekha ma'am. You can take Swati's question.
Okay, ma'am.
Ma'am, here's the question on the screen.
Question is not displayed completely.
It is displayed.
It is displayed. It is on screen.
Sir, against whom medico only, then complaint can be lodged only. Where can a complaints be? Only this thing is.
As far as against whom
question.
medical legal complaint can be lodged. So against any medical service provider complaint can be lodged. Against a doctor, against dental surgeon, against pharmacist, against nursing staff, again pharmacist, radiologist, sonologist. So patient and patient party are free to lodge complaint against anybody, but burden of proof is always on shoulder of a patient or patient party, or we may call it prosecution, to prove that whether doctor was negligent in treating the patient. If it is gross negligence, say for example, it is called in eye of law res ipsa loquitur. Say for example, if left foot is to be operated and right foot is operated, so this is gross negligence. It becomes res ipsa loquitur. Then burden of proof is shifted to treating doctor to prove whether he was negligent or not. Otherwise, patient will have to prove. But they are free to complain against anybody. As far as where complaint can be lodged, if patient and patient party are interested for compensation, then they may go with civil suit in civil court or under Consumer Protection Act. If they are interested to lodge criminal complaint, then in police station and in criminal courts. They may prefer complaint in Human Rights Commission also. If it is against government doctor, then they may write in government for departmental inquiry or for some punishment in government also. So there are so many ways as far as litigations are concerned, and they may prefer to complain before medical council also to take necessary action, and simultaneously also they may go with complaint more than one place. Say for example, complaint for compensation and complaint in criminal court also, complaint in Human Rights Commission also, and in medical council also. So they may go simultaneously for more than one complaint also.
Thank you, sir. All the
Thank
best,
you, sir.
sir.
Now the session is open for anyone to ask questions. Dr. Swati, you had questions, right?
Yes, ma'am. Sir, I just wanted to ask you that single doctors like myself and small doctors who are having a 10-bedded hospital, not equipped with ICU and ventilators. So are we, if anything happens, like the patient is meant to go to ICU and we don't have ICU in our setup only, and because of that it gets any complication, are we liable for that?
So, which kind of practice you are doing, one, where you are practicing, and with which resources you are practicing. All these points are taken into consideration whenever you are facing litigation. If you are working in remote place with limited resources, then court expect that way. If you are working in tertiary care center with all modern equipment, then court expect from you in that way. So as far as ventilator part is concerned, in one of the cases it was decided that if it is available, it's fine. Otherwise, it is not compulsory, and merely on that ground that ventilator was not there could not be the ground for litigation. But how you try to save life of patients are taken into consideration. Say, for example, if patient suffers any collapse, if you try to resuscitate, you try with ambu bag or so, then and you can refer patient in nearby center for further treatment. And if you escort that very patient with all emergency drugs, IV line, oxygen cylinder, etc., it shows your consent to save life of patient, and it becomes in your favor. So not necessary that ventilator should be in each and every nursing home. If it is there,
So,
it's fine.
sir, in case of shifting a patient like this type of emergency patient, do we need to escort her with these things, like you said?
It is always advisable to escort that very patient in the same ambulance, because in one of the cases in city of Pune it happened. Doctor escorted the patient, but doctor was in his own car and patient was in ambulance, and on the way patient suffered heart attack. He tried to resuscitate, but patient couldn't be saved, and litigation was filed and case was decided against doctor. So whenever you escort patient, you should be in the same ambulance with all emergency drugs, oxygen cylinder, IV line, etc.
So, sir, doctor is supposed to escort the patient, or any staff will do, or
yes.
any.
If you are busy with some other emergency, then equally competent person can escort the patient. And in this situation, anesthesiologist is the best person. If anesthesiologist is available, he can escort the patient. Otherwise, your trained staff, somebody should be there to take care on the way if at all patient suffers something. And for that also, again, I would like to mention, you have to visit Foxy website, and in that Foxy uniform consent, we have prepared 30 different consent. In those consent, we have prepared one consent, how to transfer patient to higher center. So we have mentioned everything, which kind of transfer document you have to give to the patient party. So you can visit Foxy website, you can download, and you can utilize in your day-to-day practice.
Sir, one more question regarding babies also. Like, I'm doing deliveries and cesareans, but I'm not having an ICU setup. So, is this mandatory to have an ICU setup?
If you are not
NICU
setup, but do you keep neonatologists present at the time of delivery?
Yeah, sure, sir. A pediatrician visit the kids.
It's fine. So if you have a practice to keep neonatologists present in labor room or in OT at the time of delivering baby, and just after delivering baby, you are handing over baby to NICU people, it's fine. And they will take decision whether baby needs NICU care or so. And they will ship patient to NICU care. No issue.
Thank you, sir. Thank you so much.
Thank you, sir. Thank you, sir, for the reverse panel.
Yes, thank you, sir.
Sir, one question, sir.
Yes, welcome, sir.
That, there are two types of negligence, that
Hmm.
civil or criminal negligence.
Yes.
How to differentiate that, whether it will be that civil negligence or criminal negligence, or there's an FIR required for criminal negligence?
In this situation, patient and patient party are free to go for litigation either in civil suit, that is CPA or civil court, or criminal cases. But as far as criminal liability or criminal negligence is concerned, it was well discussed in famous case of Jacob Matthews versus State of Punjab, which was decided in Supreme Court in 2005. So in that very case, Supreme Court came up with guideline that when criminal liability will be decided against any doctor. And just I mentioned prior also, so whenever negligence is very gross or a very high standard of recklessness, then only criminal litigation or criminal liability will be considered. Otherwise, patient will be advised to go for civil suit, but they may go for criminal case, no issue. But in court of law, to prove criminal negligence against doctor is very difficult. And this Supreme Court has come up with 3 different guidelines where criminal liability can be considered and case can be filed against doctor either under section 304 or 304A or so. So first guideline was, is there prima facie negligence on part of doctor, and how one will decide? Investigating officer is not doctor. Say for example, if it's police station officer, then he is not medical person. So who will decide that it was prima facie negligence on part of treating doctor? So in this situation, all the case papers of treatment given, or they may take statement of doctor, statement of relative, statement of staff, and they will refer all those case paper to nearby medical college and respective department. And in that very opinion from medical department, if opinion comes that it seems to be prima facie negligence on part of doctor, then only FIR will be lodged, or if at all FIR is lodged, then only further proceeding will be done. Because on mere complaint on part of patient or patient party, they will lodge FIR, no issue. But at the time of taking doctor to the court, they will have to justify that FIR, why they lodge FIR and what is the concrete reason to lodge that very FIR. And if they fail, then court will set doctor free on first visit only.
The second question, that 1 hour that later that cesarean section consent was given to. In that case, your the records like that CTG having that having progress of labor, that partogram and all that will guide, and that can protect you, that can save you.
Yes, I mentioned during one of the question as far as record was concerned, I mentioned that importance of partogram, importance of CTG and CTG tracing, and when you have counsel patient to go for cesarean section, at that point of time, what was the CTG tracing? So you can justify that cesarean was indicated at that point of time only. And if they have not given consent, and if you have taken negative consent, that we are not ready to give consent, then it becomes good defense in your favor, because it is non-compliance on part of patient.
Excuse me, sir. The session will auto end in 3 minutes. So if you want to make your vote appeal,
Yes.
first,
Naturally,
because it will end in 3 minutes.
Thank you.
So it is our humble appeal to endorse my candidature for post of President Foxy. You will receive communication from Foxy in month of May, all president and secretary of respective society, to go for nomination. So first you will have to go for nomination in month of May for me for post of president, and for Dr. Asha Jain for post of chairperson, Food, Drug and Medico Surgical Equipment Committee. And in month of August, from 1st to 10, voting will be for office bearers, that is for me, and voting for Asha will be from 16th of August to 25th of August. So it is my humble appeal, consider my seniority, sincerity, dedication, and easily availability to any Foxian friends in any odd given situation. I seek your vote, support, and all the blessings for my election candidature for President Foxy election year 2024. Thank you. Thank you very much. Yes, any
Ma'am, you
comments
are
from
muted.
anybody, or we may conclude?
Asha
For
ji,
a
ma'am, you are
holiday,
Any-
on a
any
holiday,
comment, any
spending
quick
so much
question?
time with us. Thank you. Happy Ugadi, happy Navratri, happy Sanatan New Year. And thank you, Corona Remedies, for being with us this evening and being our academic partner. Thank you, all the viewers, for logging in even on a festival day. Thank you. Thank you so much.
Yes, today is Gudi Padvo, Ugadi, Baisakhi, and in Northeast.
Baisakhi nahi hai, sir. Vishu.
Baisakhi nahi.
Bihu.
Arre, Bihu, not Baisakhi, Bihu. So all the festival on today, and it is considered of birth of earth today. This day, Chaitra Sud Padwa. Gudi Padwa is well celebrated in Maharashtra and Ugadi in South.
Sir, Chaitra Navratri is celebrated
Yes.
all over India.
Yes, Navratri all over India, but Ugadi and Gudi Padvo in respective state, they are much more, what we say, interested to celebrate that festival. Chaitra Navratri is all over India because we have two Navratri, Sardiya Navratri
Stop
and
the
Chaitriya Navratri.
telecast.
So thank you, and thank you, Corona, also.
Thank you.
Thank you, sir, and thank you, ma'am. So, with your permission, I am ending this
Yes,
session.
we can conclude.
Okay.